Patient's here.
Oh boy, got some blood going.
Yeah, this is never blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver of a vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in application
for 45 minutes of CPR. We can stop CPR with 600, 600, 600.
Welcome back to the deep dive. Today we are shifting gears just a little bit. Usually we take a broad, a wide-angle look at a topic, sort of scanning the horizon.
Yeah, the big picture.
But today we are zooming in. We're putting on a very specific set of hats.
That's right. We're donning the hats of the pediatric nursing educator.
And the exam coach.
Exactly.
Yeah.
We've been looking at our listener feedback, and we know that a huge portion of you are technically the learner.
Right.
You might be cramming for the NCLEX, you might be prepping for your CPN certification, or honestly, you might just be about to step onto a pediatric floor for your first shift, and you want to make sure your practice is safe.
Exactly. And we know the struggle. You have textbooks that are literally 1,000 pages long.
Oh, I remember them well.
You have PowerPoint slides from nursing school that are just lists of symptoms with absolutely no context.
Just bullet points.
Just bullet points. And you have that lingering anxiety of what is actually going to kill my patient, or, what is actually going to be on the exam.
And that is the noise we are here to cut through. We're going to look for the signal.
The signal and the noise.
The safe practice signal. And the topic we are diving into today is fascinating because it's a massive paradox.
It really is. We're talking about rubella.
Also known as German measles.
And the paradox, and this is our initial hook here, is that if you are a 5-year-old kid and you get rubella, it's usually a nothing burger.
Right. It's mild, it's a rash, you're fine in 3 days.
It's an inconvenience at most.
Precisely. But, and this is the critical but, if you are developing fetus, rubella is catastrophic.
Wow.
It is arguably one of the most destructive viruses for the unborn. And that is why we talk about it. We don't study rubella for the sake of the kindergartner.
No.
We study it for the sake of the pregnant woman standing next to the kindergartner.
So our mission today is to cross-reference a stack of sources. I've got the CDC Pink Book, clinical profiles, lecture notes, and we are going to build the ultimate 80-20 study guide.
The Pareto principle in action.
Exactly. The 20% of information that gives you 80% of the results on exams and in clinical practice.
We have a roadmap for this. Part 1 is the master 80-20 map.
Okay.
We need to understand the pattern exam writers love before we get into the weeds. Part 2 is the deep dive lecture a system-by-system breakdown of rubella.
And
Part 3 is the cross-linking and differential diagnosis. How do you tell this apart from regular measles or scarlet fever? Because they can look similar.
I love it. Let's jump right into Part A, the master 80-20 map. You always say that pediatric infections fall into patterns. What is the high-yield pattern for rubella?
So before we even memorize a single symptom, you need to recognize the teratogenic pattern.
Teratogenic, meaning harmful to a fetus.
Exactly. This is the highest yield concept. In the world of pediatric exams and safety, rubella is almost always a question about pregnancy safety.
Okay, let's unpack this, because usually when we talk about a sick kid, the focus is on the kid. But you're saying here the focus shifts.
It has to, 100%. The most dangerous thing about a rubella patient isn't the patient standing in front of you.
Okay.
It is the pregnant person in the room, or even the one who might walk into the room.
Wow.
This leads to a critical decision point that exam writers absolutely love. It's all about assignment logic.
Assignment logic. You mean who takes care of whom?
Exactly. Picture this question. You're the charge nurse. You have a patient in the ER with a fever and a rash, suspected rubella.
Okay.
You have a staff of nurses.
Yeah.
One of those nurses is pregnant, or maybe she's mentioned she's trying to conceive. Can that nurse be assigned to the rubella patient?
And the answer is a hard no. A definite no.
It is a hard, non-negotiable no. You just don't take that risk. If a nurse is pregnant, she should never, ever be assigned to a rubella patient, confirmed or even suspected.
And why is the risk so high?
The risk of congenital rubella syndrome, or CRS, if she's unvaccinated or maybe her immunity has waned over time, is just too high. especially in the first trimester.
The sources were very specific about that timing, right? The first 12 weeks.
Yes. The Pink Book source, which is sort of the Bible for vaccines, specifically notes that the risk of CRS is highest and the defects are most severe if that infection occurs in the first 12 weeks of gestation.
And that's because what's happening then?
We're talking about the time when organogenesis is happening.
The organs are being built.
Literally. The heart is forming, the eyes, the ears, the brain. The virus gets in there and just, well, it stops the process.
It's like pulling the permit on a construction site while the foundation is being poured.
That's a perfect analogy.
Yeah.
If you stop the building process at week 8, you get a very different and much more devastating result than if you stop it at week 30.
So that's the teratogenic pattern. That's number one. What's the next pattern on our map?
The isolation pattern. This falls under infection control, and this is where people get tripped up on timelines.
Okay.
The priority action is droplet precautions. But here's the trap, the 7 and 7 rule.
7 and 7. Break that down for us.
The sources are pretty consistent on this. A patient is contagious for about 7 days before the rash appears. And then for another 7 days after the rash appears.
Wait. 7 days before. So they're walking around school, the grocery store, spreading the virus, and they don't even have a spot on them yet.
Exactly. And that is the timeline trap. By the time you see the rash and think, oh, I should isolate this kid, they have already been spreading it for a full week.
Wow.
This is a classic exam setup. The question will describe an exposure that happened 5 days ago before the rash appeared and ask if the contact is at risk.
And the answer is absolutely yes.
Absolutely yes.
That is terrifying from a public health perspective, but excellent to know for an exam. It sort of feels like closing the barn door after the horse is bolted.
In terms of community spread, yes, it's tough.
Yeah.
But in the hospital, isolation is about preventing further spread. If that child is admitted, they are still a hazard to the other patients on the floor for another week.
Let's clarify droplet precautions, because I feel like students often confuse this with airborne.
They do, all the time. Rubella travels in large droplets from sneezes and coughs. Physics dictates these droplets are heavy. They fall to the ground within about 3, maybe 6 feet. They don't hang in the air for hours like measles or tuberculosis, which are airborne.
So for droplet, you need a surgical mask, not an N95 respirator.
Correct. But here is a clinical, critical piece regarding cohorting.
Putting patients in the same room.
Right. If you're short on private rooms, which happens all the time in PEDs, can you put a rubella patient with someone else?
I would think no.
Only if the other patient has confirmed rubella. You absolutely cannot cohort a rubella suspect with an immunocompromised child or child with a different virus. If you put a rubella kid in with an RSV kid, you have just created a disaster.
You've cross-contaminated and made everything worse.
Exponentially worse.
Okay, so we have our patterns. We know to watch out for pregnancy, and we know the tricky 7 and 7 rule. Now, let's move to part B, the system-by-system lecture. Let's really get into rubella itself.
Let's do it.
We always like to start with a one-liner identifier. If rubella had a tagline, what would it be?
It would be the 3-day measles, or maybe the silent sniper.
Ooh, I like silent sniper. Why that?
Because clinically, for the child, it's a generally mild, self-limiting viral rash. It comes and goes quickly, hence 3-day measles.
Right.
It's distinct from rubeola, which is regular measles and much, much nastier. But it's a sniper because while it looks mild on the surface, it's targeting the unborn with deadly accuracy.
Let's get into the patho. Plain language, but accurate. What is actually happening inside the body?
So the agent is the rubevirus. It's part of the Togaviridae family and more recently classified under Matonaviridae. But for your purposes, just know it's an RNA virus.
And how does it get in?
Respiratory route.
Yeah.
You breathe it in. It enters through the nasopharynx, so the nose and throat.
Okay.
It sets up shop and starts replicating in the lymph nodes of the neck. That's its first stop. From there, it causes viremia.
Which is just a fancy way of saying the virus spills into the bloodstream.
Exactly. Virus in the blood. And once it's in the blood, it can go everywhere. The viremia spreads to the skin, which causes the rash we see. But critically, it spreads to the placenta.
And this is where the real damage happens.
This is where the damage is fascinating and horrifying. In a fetus, the virus acts by destroying cells and, crucially, by stopping cell division.
Stopping cell division, you mean mitosis?
Yes, mitosis arrest. It literally tells the cells to stop dividing. Imagine a developing heart or an eye that needs to grow a certain number of cells to form correctly.
Right, it has a blueprint.
It has a blueprint. Rubella comes in and says, stop. The cells don't divide. The organ doesn't grow. That leads to growth retardation and all kinds of structural defects. It's not just attacking tissue, it's preventing the tissue from ever being built in the first place.
That explains why the timing matters so much. If you stop the building process at week 8, you get a very different result than if you stop it at week 30.
Precisely. The earlier the infection, the more fundamental the damage.
Okay, let's talk about presentation. How does this look when a patient walks in? Does it look different in a baby versus an adult?
Huge difference. And this is a need-to-know distinction for exams. In infants and young children, they are often asymptomatic or the symptoms are so mild.
So you might not even know they're sick.
You might not. Usually the rash is the first sign.
So no warning, just boom, rash.
Often, yes. Mom notices spots when she's giving a bath, and that's it. But in older children, adolescents, and adults, we see a prodrome.
A prodrome. That's that period of feeling gross before the main event.
Right. For about 1 to 5 days before the rash, they feel crummy, low-grade fever, malaise, headache, maybe some mild conjunctivitis, pink eye, and coryza, which is a runny nose. Just feels like a mild cold.
There was a specific finding for adult females in the source material that caught my eye. It seemed really high, like 70%.
Yes, this is a major nice-to-know context that becomes need-to-know if you're treating adults. Up to 70% of adult women who get rubella experience arthralgia or arthritis.
So joint pain.
Significant joint pain.
Yeah.
Fingers, wrists, knees. It can be quite debilitating. It can last for a month or more. It's rare in children and rare in men, but for women, it's a hallmark. If you have an adult woman with a rash and her wrists are killing her, you have to think rubella.
That is fascinating. Okay, let's get into the core of the exam content. The need-to-know assessment findings. We are standing at the bedside. What are we looking for?
First, let's characterize a rash. It's maculopapular.
Which means?
Flat red spots macules and raised bumps papules, a mix of both. But the direction is key. It is cephalocaudal.
Fancy word for head to toe.
Correct. It starts on the face and spreads down to the toes, and it moves fast. By the time it reaches the legs, it might already be fading from the face.
And how long does it stick around?
It's usually gone in about 3 days. Hence, 3-day measles.
And how does it look compared to regular measles?
It's fainter. Regular measles, rubeola, looks angry, deep red, and the spots coalesce. They merge together into big blotches.
Oh.
Rubella stays more distinct, more pink, less angry. And here's a weird clinical pearl from the sources. The rash can be more prominent after a hot shower or bath.
Interesting. So if they come in overheated, it might look worse than it is.
Exactly. Or a parent might notice it for the first time after bath time.
What about the lymph nodes? You mentioned they replicate there.
This is a classic textbook clue. You are looking for distinctive swelling in 3 specific areas.
Okay, what are they?
Postauricular, which is behind the ears, posterior cervical, on the back of the neck, and suboccipital, right at the base of the skull.
Behind the ears is the big one I remember.
That's the one they love to test. If you feel swollen nodes behind the ears combined with a rash, like we've described, rubella should be very high on your list of possibilities.
And what about inside the mouth? We always hear about cup-lick spots with measles. Does rubella have an equivalent?
Sort of. They're called Forsheimer spots.
Forsheimer?
Yeah, Forschheimer. These are small red spots, or petechiae, on the soft palate.
The back of the roof of the mouth?
Exactly. Now, the source notes that these aren't 100% diagnostic. They can happen in other things. Okay. But exam writers love to throw them in as a clue. If you see red spots on soft palate in a question stem, don't rule out rubella.
How does that look different from strep throat? Strep gives you petechiae on the palate, too.
It's hard visually. They can look very similar.
Yeah.
But context is king.
Right.
Strep throat usually has a high fever, a very sore throat, and classically, no cough or runny nose. Rubella comes with the coryza, the runny nose, the cough, and then the body rash. You have to look at the whole patient, not just their palate.
Okay, so we suspect it, we see the rash, the nodes. How do we prove it? What are the key diagnostics?
Well, clinical diagnosis is unreliable because so many viral rashes look alike. You need labs to be sure.
What are we ordering?
PCR from the nose, throat, or urine is the gold standard for detecting the actual virus. But for immune status, we look at IgM antibodies.
And IgM means minute, like the infection is happening right now.
I use IM-mediate. IgM indicates a recent acute infection. The optimal timing to draw this is about 5 days after symptom onset.
Why the delay?
If you draw it too early, the body hasn't had time to mount that antibody response, so you might get a false negative.
Okay, so we have a diagnosis. We've done our assessment. What are our priority nursing interventions? What do we do first?
Immediate isolation. That's number 1. Get them into a room, put them on droplet precautions.
Which means a mask for anyone entering the room.
A mask for you and a mask for the patient if they have to leave the room for any reason. A private room is strongly preferred.
And treatment. Is there a magic pill?
Sadly, no. It's viral. So supportive care is the name of the game.
What does that entail?
Fluids for hydration, because fever can dehydrate them. Antipyretics like acetaminophen or ibuprofen for the fever and that joint pain we talked about. No specific antiviral cure exists. It resolves on its own.
And school. When can they go back?
This goes back to the 7 and 7 rule. But for exclusion, the official CDC guidance is to keep them home from school or childcare for 7 days after the rash onset.
Okay. Now we need to talk about the crash list, the complications. You mentioned it's usually mild, but things can go wrong.
They can. While CRS is the big one for the fetus, the patient themselves can have issues. One is thrombocytopenia.
Low platelets.
Right. It happens in about 1 in 3,000 cases. So as a nurse, you are watching for bruising, petechia on the skin, or bleeding from the gums or nose.
And the really scary one.
Encephalitis.
Yeah.
Brain inflammation. It's rare, about 1 in 6,000 cases, but it can be devastating or fatal.
What are the signs of that?
You're watching for any change in level of consciousness, confusion, seizures, or a severe unrelenting headache with a stiff neck. That's a neurological emergency.
But let's go back to the exam writer favorite. The biggest complication isn't for the child, it's for the fetus. Congenital Rubella Syndrome, CRS. We need to drill this down. What does a CRS baby look like?
There is a classic triad of defects you must memorize. If you memorize nothing else about CRS, memorize this triad.
Okay, I'm ready.
1. Deafness. Sensorineural hearing loss. This is the most common finding. 2. Eye abnormalities, most commonly cataracts, which are cloudy lenses, but also glaucoma or retinopathy. And 3. Cardiac defects, specifically patent ductus arteriosus, PDA, or pulmonary artery stenosis.
Deafness, eyes, heart. Got it.
That's the triad. But there's a distinctive skin finding, too, which is also high yield. The blueberry muffin rash.
That sounds cute, but I assume it's not.
Not cute at all. It represents dermal erythropoiesis.
Meaning?
Basically, the baby is making red blood cells in the skin because the bone marrow isn't working right or is just overwhelmed by the infection. It looked like purple or blue nodules scattered over the skin.
Like little bruises under the skin.
Exactly. It's a sign of severe systemic infection. If we see a blueberry muffin baby, what are we thinking?
We are immediately thinking a torch infection.
Yes. TORCH, toxoplasmosis, other, rubella, CMV, herpes. It triggers an immediate massive workup.
Okay, let's pivot to prevention. This is all preventable, right?
100%. We have the MMR vaccine measles, mumps, rubella, or the MMRV, which adds varicella, or chickenpox. It's a live attenuated vaccine.
And live is the key word there.
Huge keyword. It's so important. Because it's live, it carries specific contraindications you have to know.
Number 1 has to be pregnancy.
Absolutely. You cannot give a live virus vaccine to a pregnant woman. The theoretical risk to the fetus is just too high.
And the second big one?
Severe immunocompromise. Someone with advanced HIV and very low CD4 counts, or someone on high-dose chemotherapy. Their body can't handle even a weakened virus.
What about the timeline for pregnancy? If a woman gets the shot, how long does she need to wait to get pregnant?
She must avoid pregnancy for 4 weeks after vaccination. The CDC recommendation used to be 3 months, but they've shortened it to 4 weeks based on data. This is a standard discharge instruction.
I saw a trap in the notes about egg allergies.
Yes, this is a classic myth that just won't die. People think because some vaccines are grown in egg cultures, you can't give MMR to kids with egg allergies.
And the answer is?
The source explicitly states that egg allergy is not a contraindication. Even a child with a history of anaphylaxis to eggs can and should receive the MMR vaccine, usually in a setting where they can be monitored.
That is a point for the listeners to highlight. Don't fall for the egg trap.
Another trap is confusing it with other allergies, neomycin or gelatin allergies. These are components of the vaccine. So if the question says the kid had an anaphylactic reaction to gelatin, then you hold the vaccine.
But not for eggs.
Not for eggs.
I want to talk about side effects because parents call about this all the time. The mini measles reaction.
Yes, this is a massive parent education point. It's so important to set expectations. You give the MMR shot, the parent goes home, then 7 to 12 days later, the phone rings.
And they're panicked.
Panicked. My child has a fever and a rash. You gave them the measles.
And you have to talk them off the ledge.
You do. But this is an expected physiological response. About 5 to 15% of kids will get a fever, sometimes as high as 103 degrees Celsius. And about 5% get a rash. It happens roughly a week and a half after the shot.
Why that delay? It's not like with a Tylenol reaction that happens right away.
Because it's a live virus.
Yeah.
It has to replicate a little bit to stimulate the immune system. That replication process takes time. But, and this is critical, this is not the contagious wild-type disease.
Right.
It is a vaccine reaction. It's non-transmissible in the standard sense. The child is not contagious.
So the advice to the parent is?
Don't panic. This is normal. Treat the fever with acetaminophen or ibuprofen. It will pass in a day or two. This is a good sign. It means the vaccine is working and their immune system is building protection.
We have to address the autism link.
We absolutely have to be definitive here. The Institute of Medicine, which is now the National Academy of Medicine, has reviewed the evidence extensively. They explicitly refute, and that is the word the source uses, refute, any causal relationship between the MMR vaccine and autism.
It's important to have that firm language. Refute. Not, we think it's unlikely, but the data says no.
Correct. The original study was retracted for fraud. There is no link. But there is a real, albeit rare, risk we need to be honest about: febrile seizures.
Talk to me about that.
The risk of a febrile seizure is about 1 in every 3,000 to 4,000 doses of MMR.
Which is tied to that high fever it can cause.
Exactly. It's slightly higher if you use the combined MMRV with the varicella component as the first dose in toddlers, so from 12 to 15 months.
Wait, really? I thought one poke was always better.
Usually, yes, but the data shows that for that specific age group, 12 to 47 months, the risk of febrile seizure is about twice as high with MMRV compared to giving MMR and varicella as 2 separate shots on the same day.
That's fascinating.
It is. For the second dose of 4 to 6 years, MMRV is preferred because that increased risk disappears. It's a very specific age-related phenomenon.
That is a deep dive nugget right there.
Absolutely.
Got it. Now, I want to move to a section that is specific to our masterclass approach. We need to connect this disease to development and milestones. How does rubella, specifically CRS, impact a child's development?
This is critical. If we are looking at acquired rubella in a healthy school-age kid, the impact is minimal.
Right.
Short-term disruption of school. Maybe they miss a soccer game. There are no long-term developmental issues usually. But for the CRS baby, the developmental threat is global. It affects everything.
Let's break that down.
Think about the triad again: deafness. Hearing is the absolute foundation of speech and language acquisition. If a baby is born deaf from CRS, they will have profound speech delays unless we intervene very, very early with things like hearing aids or cochlear implants and sign language.
And the eyes, the cataracts.
Visual impairment impacts motor development. Babies learn to reach and crawl by seeing things they want. If they have cataracts, that motor drive is blunted. Plus, visual tracking is a huge cognitive milestone.
So the nursing action here isn't just treat the virus.
No, the virus has already done its damage in utero. The nursing action is early intervention referral. Immediately. These babies need audiology, ophthalmology, cardiology, physical therapy, occupational therapy, and speech therapy from day one. We are playing catch-up from the moment they are born.
There was also a chilling rule about the contagious baby.
Yes, this is a massive safety and developmental issue. Babies born with CRS shed the virus in their urine and secretions for a very long time.
How long?
Up to 1 year, sometimes longer.
1 year. So this baby is basically a walking or crawling biohazard to susceptible people.
Exactly. The virus has integrated into their system and they're constantly shedding it. Think about the developmental and social impact of that.
It's huge.
We have to isolate this baby from susceptible populations. Grandparents, if they aren't immune, that's a risk. But especially pregnant aunts, family friends, daycare providers.
So no standard daycare?
This baby cannot be in a standard daycare setting if there are unimmunized children or pregnant staff. It creates this bubble of isolation around the family that can severely impact bonding and social support at a time when they need it most.
Is there an off-ramp before the 1 year mark? Can they be cleared?
Yes.
Yeah.
The protocol is that infants should be screened monthly after they turn 3 months old. If you get 2 consecutive negative tests on nasopharyngeal swabs or urine, collected at least 1 month apart, then you can consider them non-contagious.
But until then, strict contact and droplet precautions.
Yes, and that is heavy. It really reinforces why vaccination is a community responsibility, not just an individual choice.
Absolutely. Okay, let's move to Part C, cross-linking and consensus. We need to make sure we don't confuse rubella with its lookalikes. Let's do a quick comparison. Rubella versus rubeola, German measles versus regular measles.
Okay, visualize a table in your mind. Column A, rubella. Column B, rubeola.
Let's do it.
For rubella, the rash lasts 3 days. The fever is low grade. The keynote finding is postauricular, behind the ears. And the kid generally feels, okay, mildly ill.
And for rubeola?
Rubella.
Yeah.
The rash lasts 5 to 6 days or longer. The fever is HIGH, 103, 104 degrees Fahrenheit. The key mouth finding is Koplik spots, those little white spots inside the cheek.
The 3 C's?
The 3 C's: cough, coryza, and severe conjunctivitis. With rubeola, the patient looks devastatingly sick. They're miserable.
So rubeola is the big bad wolf, and rubella is the sneakier, quieter cousin.
That's a great way to put it. Rubeola knocks you down hard. Rubella might just tap you on the shoulder, but it carries a knife for the fetus.
What about scarlet fever? That's another red rash.
Right. But the scarlet fever is bacterial. It's from group A strep. The key differentiator is the texture of the rash.
Texture.
Scarlet fever feels like sandpaper. If you run your hand over the child's chest, it feels rust. Rubella is smooth maculopapular. Also, scarlet fever has the strawberry tongue and often a very red sore throat. Rubella does not.
Sandpaper versus smooth. That's a great exam differentiator.
One note on consensus from our sources: we notice a slight discrepancy in the incubation period. Some sources say 12-23 days, others say 14-21.
What's the safe answer for an exam?
The safe exam answer and the average is 14 days. If you stick with 2 weeks, you're usually in the clear.
And the arthritis rates?
Also vary slightly. Some said 25%, others up to 70% in women. The qualitative fact is what matters. It is common in adult women and rare in children. Don't get hung up on the specific percentage, just know the demographic.
What about roseola, another rash disease?
Ah, yes, exanthum subitum. Roseola is the high fever then rash disease.
Okay, explain that.
Roseola starts with a terrifyingly high fever, like 103, 104 for 3 to 5 days. But the kid often acts surprisingly normal. They're not that sick. Then the fever breaks, it just vanishes, and boom, the rash appears.
So the rash comes after the fever is gone.
Exactly. Rubella is the opposite. The fever and rash happen together, or the rash comes after a mild prodrome. If the fever goes away and then the rash starts, you should be thinking roseola, not rubella.
Fever breaks, rash takes. That's roseola.
That's a great mnemonic.
We are coming up on the end of our deep dive. Let's bring it all home with a summary. What are the key takeaways our listeners need to walk away with?
Okay, let's distill it. Number 1, rubella equals German measles equals 3-day measles. It's generally mild for the kid, but incredibly dangerous for the fetus.
Number 2.
The rash starts on the face and moves down, cephalocaudal, and you'll see those swollen postauricular lymph nodes.
3.
The vaccine, MMR, is a live virus, which means no giving it to pregnant women or the severely immunocompromised. And women need to wait 4 weeks after the shot to conceive.
4.
The CRS triad: deafness, cataracts, and cardiac defects. Know it, love it, don't miss it.
And 5.
Isolation. Droplet precautions. The patient is contagious from 7 days before the rash to 7 days after. And that blueberry muffin rash in a newborn is a sign of severe congenital infection.
Perfect summary. And for that final provocative thought, we read these statistics, and one of them just really stood out.
It did. The one from the clinical profile source. It said that 25 to 50% of rubella cases are asymptomatic.
Up to half of all cases have no symptoms.
Up to half. So imagine a world where we stop vaccinating because it's a mild disease. We get that sometimes. It's just a little rash. In that world, you have people walking around in grocery stores, on buses, in doctors' waiting rooms, shedding this virus, completely unaware that they are infected. And standing right next to them is a woman in her first trimester of pregnancy who maybe couldn't get the vaccine for some reason or whose immunity has faded.
And she has no idea she's being exposed.
None. The vaccine isn't just for the child who gets the shot. It's a shield for the unborn. When you vaccinate a child against rubella, you are actively protecting a future baby from being born blind or deaf, or with a heart that needs multiple surgeries to fix. That is the real weight of this topic.
That puts it all into perspective. It's not just about the patient in the bed, it's about the entire community, present and future.
Exactly.
Thank you for unpacking this with us. To all our learners out there, whether you're cramming for finals or prepping for your shift, you've got this.
You really do. Trust your training, look for these patterns we talked about, and always, always keep your patients safe.
We'll see you on the next deep dive. Close the textbook, take a breath. Good luck.
You've got this.